In health coaching and beyond, Ollie and I aim to mix up conversations between the two of us, chewing over hot topics, latest news and emerging ideas, but also bringing you conversations with thought leaders and people we admire in the field of health coaching and beyond. People we hope will help you think really well and spark interesting ideas for yourself. Pain is one of the most common reasons people seek help and one of the most misunderstood. For many, living with persistent pain, it stops being just a physical experience and starts to shape identity, confidence, and hope. Too often, the conversation ends at scans, diagnoses, or learning to live with it. On health coaching and beyond, we're interested in what happens when we widen that lens, when the pain is understood not just as something to fix, but something to make sense of. Today, I'm joined by Dr. Deepak Ravindran, pain specialist and author of The Pain-Free Mindset, and Lee Vaughan, whose expertise comes from lived experience. Together, we're exploring what actually helps people move forward without minimizing pain and without false promises. Okay, welcome, Deepak and Lee. Really good to have you on the podcast. And for those of you who don't know you, I think it'd be really good if you could just introduce yourself. So maybe start with Deepak and just give us a few lines of introduction, Deepak, and then we'll come to you, Lee.
Thank you, Tim, and thanks to Ollie as well for having me on your podcast at the beginning of 2026 and along with Lee as well. So my name is Deepak Ravindran. I'm a consultant in pain medicine and lifestyle medicine. I work in the area of Berkshire, presently in primary care, and I do have some teaching responsibilities with Teesside University and Reading University. But most importantly, I'm an associate pain coach with Peak Health. So thank you for having me, guys.
Great. Thanks, Deepak. And Lee, tell us about yourself.
Yeah, I'd echo the same. Thank you very much for sort of having us both on this, Tim, and Ollie as well, because I know it's both your project, this one. So as well as being an associate trainer with Peak Health Coaching, I'm a health coach within the NHS, working within Dr. Ollie Hart's PCN in Sheffield, but I now work as the Lived Experience Service and Development Lead with Pure Unity Health, which is a role that I came to about 2 or 3 months before the end of last year. And prior to that, I'd been working as a health coach with them in their pain management services. And my qualification for working within a pain management services is my 30 years of training. That lived experience of having lived with chronic pain for well over 3 decades, probably 3.5 decades now. And very grateful to people like yourselves, Tim and Ollie and Deepak and the other people that give the voice out there for bringing the lived experience to the table to be part of the conversation.
Thank you, guys, and thank you for being so succinct as well. And I'm really interested to kind of how you found your way into pain management, Deepak. And I suppose for me, I found my way into it by necessity because when I was working as a GP, I found people with long-term pain really difficult to manage. And that's hence I got a job in a pain clinic. I thought, well, this is what I need to try and help or maybe offer people a little bit more. So that's how I got into it, because I felt I needed something else to give people. But it is it's quite a niche specialty. So I just wondered, how did you find your way into that, Deepak?
Well, a great question, Tim. I think for me, my undergraduation was back in India, where I did a fair amount and I didn't recognize chronic pain as that. I was more doing the interventional part when I did my post-graduation in anesthesia, both in India. And then when I came to the UK, I qualified again through the entire anesthesia training within the Oxford region. And it was then around the 3rd or 4th year after I finished my Royal College exam that I started becoming more interested in pain, because I felt that pain was one of those subjects that sat at the intersection of medicine, of psychology, of neuroscience. And to a certain extent, being an anesthetist, I was interested and maintained an interest in the interventional aspects, because I felt that was the fun, exciting bit, the ability to get to any nerve in the body as long as I had a long enough needle. And that was satisfying in itself. And to block it, and you saw the immediate results in acute pain, I naively thought that the same thing extended to chronic pain, and that would be a fulfilling option. So when I got a fellowship in UCL, I jumped at it and I thought, well, you know what, this is what I'd like to specialize. This is where I see the biggest opportunity for research, for advancement and innovation. And that's why I took up pain management. I started in 2010 as a consultant within the Royal Berks Hospital there. And that was the time I went into pain management as, 2 sessions or 3 sessions a week apart from anesthesia. And I thought, well, you know what? Life's going to be good. I can do an injection and then I can see a few patients in clinic. And in some ways, I think I arrived at the same junction that you talked about, wherein by 2014, I realized that while I knew how to do the injections, while I knew how to give the medications, that was not giving the outcome that the patients wanted, that the patients needed. And I was seeing that a lot of what I had been taught wasn't necessarily right anymore, wasn't necessarily the whole picture. And I think that's been my journey to where I am now. It's about 8 to 9 years of rediscovering the knowledge, but also rediscovering that there is an entirely different way to do pain management and pain care in a much more compassionate, patient centered, and in a manner where I think the outcomes are radically different to what I had trained as a consultant.
Yeah. It's interesting, isn't it? Because I suspect that a lot of people will be surprised, maybe, who haven't come across pain management, that actually anaesthetists tend to be the people who are running those secondary care, those hospital-based clinics. It seems unusual, but you've explained it well, but also you've been on the journey that you've been to. So do you want to say a bit more about that?
Yeah, the thing is, I think the UK and probably the Eastern Hemisphere are unique in that way that a lot more pain specialists are having a background of anesthesia, because I think the biomedical model really lends itself to saying that someone who's good at blocking the nerves, the interventional element, someone who can give pain medication drugs perioperatively and postoperatively. And so you can see why anesthesia and therefore having a parent specialty as anesthesia was a natural extension to just going into the chronic pain space. I think the US and the probably Western Pacific side, they've been much more broader. You have a lot more specialties. And in the US, for example, pain specialists can be having a background of neurology, can be from physiatry, can be from a variety of other specialists. And I think that kind of broad-based background is probably much better because you have a wider experience base when you come in there. I think we're changing now. The fact that in the UK in the last 5-10 years, we've got credentialing, we've got the GMC as well as the Royal College recognizing that you can have specialists from other specialties other than anesthesia to be interested in pain is really making a difference. And I think in the next 5-10 years, we're going to have pain specialists who will hopefully have a good foundation of pain science knowledge, who are going to have the equipped knowledge of communication, coaching. But I think that is the journey that we want to be part of and actually create the ecosystem in which that can flourish.
Yeah, nice one, Deepak. Yeah, thank you. Lee, I'd love to hear a little bit from you because you get to share your story a number of times, I suspect. You certainly get to share it on the courses that we run, but you also get to share it more widely than that. So I'll be really interested to hear a little bit about, what is it, the part of your story that really resonates with people when they hear it. So could you say a bit about that?
Yeah, I do. I get to share it a lot, and I get the safety and the space to do that. And the story, in all honesty, changes for the audience, different depths for different people, because there are elements of it that are really, really difficult. But I think the word there is resonate, isn't it? It's a really, really crucial word. And if I'm speaking to patients and I'm sharing that journey, then that understanding and that shared experience of that 30 years of undiagnosed pain, people start to think, wow, this guy gets this then. This guy really gets this. The being sort of January 2022, fixed on 28 tablets a day, it's something that patients I talk to, they recognize that overwhelm of so much medication. And I think in sharing that story, whilst I'm very careful with the next element of the stories, is, you'd maybe think that the resonating came in the explanation of the ACEs, the explanation of the CPTSD, the PTSD, There's a lot of difficult stuff in the story, but I'm not sure that's the bit. It may resonate with the patients a little bit because they'll understand. Yeah, I've had a pretty bad deck of cards dealt as well. So maybe there's something we're a little aligned on here. But I think in terms of healthcare professionals, whilst that opens eyes, and I think it draws breath. Wow, 35 years, 28 pills a day, the ACEs, the PTSD, CP. Wow, that's terrible. I'm not sure that's the bit that resonates, because upon sharing that story, and I did it with Newport with Deepak last year, and it was actually Cormac Ryan that came to speak to me afterwards and sort of said that one line in there is incredible, and he's not the only person that's pulled me to one side and said that there's something about that line. It's really powerful. And that line was, I've always sort of said, for 30 years of undiagnosed pain, my pain was never, ever there to be seen, but it was always there to be heard. And for some reason, that one really seems to land. Maybe it points to the fact that we as human beings have this complete understanding that we don't have enough time for each other. Society, certainly the healthcare system's not built, at the moment to maximize time like we can as coaches. We're spending an hour with people, but that missing element for patients is time to share the story, time to talk to someone and unload everything we want to unload. And then for the clinician, the time to hear it, and the time to hear it safely and to hear it once, as you allude to on the coaching, Tim, it's okay to hear war stories, but can we aim to hear them once? Well, we need time to do that. So I think that's why that particular line seems to resonate. And I use it a lot now to try and encourage healthcare professionals and people to look more towards that psychosocial or social psycho side of chronic pain. And in terms of resonating, that's the phrase that seems to really catch people.
Yeah, thanks for sharing that. And it's resonating with me as you're saying that. There was a couple of things you said in there. I just want to make sure everyone's familiar. You said ACEs, and I think you talked about PTSD, and I think people will be familiar maybe with the second one, but ACEs, I don't know if you can just explain a bit about that for people.
Yeah, and please correct me if I'm wrong on this, Deepak, or Tim, because you guys are the experts on this. I've just got the lived experience. It's the adverse childhood experiences. I think very often we overlook childhood, we overlook young adolescence, what happens in school, small things that shape who we are as people today. And there can be very, very small things that happen that can reside in our body as trauma, but we don't recognize. And it's as Peter Levine and Gabor Mate allude to, is trauma is not what happens to us, it's what happens inside of us as a result of what happened to us in the absence of a benevolent other. That's a really important last little bit. So, very often people say, well, that happened to me, I'm fine. And that happened to him and he's fine. We are all complicated individuals. And what's happened to us in childhood particularly, it shapes who we are today. And often in persistent pain is a real key underlying factor for why we feel the way we do.
I'm so glad I got you to fill in the gap there, Lee, because I don't think I've ever heard such a really well articulated version of what an ACE is. So thank you so much for sharing that in that way. It feels really comprehensive. Deepak, anything to add?
No, I really would not have anything more. Lee's done the really good job of explaining what that is. And I just probably would want to raise that awareness of what he said, the benevolent other, because that's so important. And we recognize that in the medical literature as PCES, protective child experiences. We talk a lot about adverse childhood experiences. I'm a big fan. I'm very passionate about trauma-informed care, and I want to raise awareness of the impact that adversity, persistent adversity and stress has on a developing nervous and immune system. I'm first in line to raise awareness about it. But of late, in the last 4 or 5 years, I've also realized that the benevolent other that Lee refers to, the protective childhood experiences, how can we ascertain that children may have adversity, but can we also provide protective childhood experiences? Can we also ensure that the nervous and immune system has the opportunity to feel safe? Because every time we take a chance to provide safety, we are giving the nervous and immune system the space, the time to calm down, to relax, and to do its own repair. And I think that is what's really important to come out in that literature.
Yeah, thank you so much for sharing that as well. That's really, really helpful to think about that as well. I'm gonna come back to that because I think what you said, Lee, is about people feeling that they're not heard and not seen. or the pain's been there to be heard, but they're not seen. And I think that is the thing that you've said it most resonates with people. And I think it's really important. And I think one of the reasons that people are not seen or heard or don't feel seen and heard is because pain is really not very well understood. And pain science has really moved on quite a lot in these last few years, I would say specifically. And I think my journey has really come on in the last few years. So it'd be really good to kind of update people a little bit in terms of our current understanding of pain. So maybe I'll start with Deepak, because you've written a book, Deepak, called The Pain-Free Mindset, which is an excellent read. But I would love for you to just explain just briefly. So what does a pain-free mindset mean? And maybe what does it not mean?
First of all, I think I've often heard from a lot of people who both read my book, but people who've looked at the cover of my book and put away and been put off by the word mindset. And to me, I didn't mean that it's all in the mind. And I think this is something I would like to take pains to point out, that it's not about how you think about it, but in a way, it's an ability to restore agency and understanding. In my own sort of simplistic view, for me, the mindset was essentially an acronym wherein all I said was, let's not throw the baby out with the bathwater. Let's say, okay, there is a role for medications. There is a role for the mainstream traditional interventions and surgeries at the right place, at the right time, for the right patient. But what I said is, okay, the M is the medications, I is the interventions. But can we pay attention to the N, which is the neuroscience that has changed so much? Can we pay attention to diet and nutrition? Can we have a talk about S for sleep? Can we have a mention about how exercise and physical activity makes a difference to pain? And can we put in a good word there for T, the therapies of mind and body? Not just leave it at CBT or ACT, but actually look at the wider ways of calming the nervous and immune system. And that was what that approach was. Can we have a reframe of that mindset? Because if you can deploy that in a strategic manner, in a curated manner, in a personalized approach, then there are enough patients that we see these days, anecdotes and recovery stories that we understand, but people become pain-free. So it's not an impossible dream, but it is something that we need to be cautiously suggesting. And I think that's the biggest message with what I wanted to convey in the book, is that there is hope. Because for a long time, for 30, 40 years, what we've been teaching in pain management is, we'll try this injection, we'll have to do the surgery, and if not, we'll teach you how to just live with it. And that's what the purpose was, just, okay, how do you live with it? But I think even psychology has moved, behavioral therapy has understood, and what has changed in neuroscience and in this latest understanding of the last 10, 15, 20 years is that there are neural circuits in the spinal cord and the brain. And these neural circuits fire in a different manner. They end up being wired differently. And if they have been receiving informations of threat or danger from multiple sources, including the immune system or the endocrine system or the external body and the society or the internal gut and the organs, then the information to the nervous system is of threat and danger. And that itself can manifest as a sensitization of the various nerve circuits, and that can present itself as a pain experience. And in the book, and even in the scientific definition, we've now decided that there would be a word for the biology of it. The chemicals that get released at the site of injury, we call that as nociception. But then that signal has to be converted to an electrical signal, which has to travel within the nerves, go to the spinal cord, go to the brain. And when the signal reaches the brain has this really marvelous, fantastic ability to look at the signal, ask itself the question, have I expected this signal? Have I predicted this signal before? What did I plan to do on the previous prediction? What did I do on the previous experience? Have I never experienced this before? Did my parents experience it? Did a digital media person experience it? What did they do to protect themselves? And the brain executes this really complex set of prediction and processing of the signal. And if it decides that the sum total is, I need to protect, that is when it brings about the experience of pain. So pain is an emergent decision by different parts of the nervous system, the immune system, the endocrine system, whereas nociception is just the biological signal when you get hurt, when you get injured, when you have a surgery. And I think understanding this separation between nociception and pain is so key, because when you know that there is nociception, so blood tests that show elevated inflammation or scans that are congruent with the injury, then you can get the best benefit from the end and the eye, the medications and interventions. But for the experience of pain, the emergent output of prediction and protection, then that is where the opportunity comes in retraining the nervous system, providing safety to the immune system using nutrition, and optimizing for sleep and movement, and getting the calming of the nervous and immune system using mind-body techniques. And I think that is the new neuroscience, is that recovery is possible, but use a different set of strategies, have a different set of toolkit. And this means that patients don't just need education alone. They need some coaching. They need that support to feel confident, to feel that agency, to feel empowered, and to then take this set of options and create a toolkit for themselves, run with it, and be helped and supported to practice it, retrain their nervous system to build new nerve circuits. That is the recovery opportunity. That's the hope. That is the holy grail we should all be moving to in pain care in the next 5, 10, 15 years.
Yeah. And I'm loving that kind of hopeful message. And thanks for explaining about what is going on in the body. And you've done that really beautifully. But I think I have been guilty over my 2 decades in general practice of saying to people, well, it's a long-term condition. You've got to learn to live with it. And I now think actually my job, and maybe the job of us going into the future, is also helping people to live without it. I'm not saying that's going to be possible for everyone, but there was a bit more hope. That's what I'm hearing from you. There's a bit more hope than I thought there was before. And I suppose I'm thinking a little bit like in type 2 diabetes, we used to kind of go, well, yes, it's a long-term condition. You've got to learn to live with it. But now we are seeing some people being able to reverse that and be in remission. So I'm hopeful that the same thing applies to pain. And I suppose that's been my biggest learning over these last few years, I would say, is feeling a bit more hopeful than I was before. Yeah.
I think that is, in medicine, Tim, I think we're often told that we make a diagnosis and we then prescribe something. What we haven't factored in is the ability of the body to do its own repair, and that it can do its repair. And we now are asking the more fundamental questions of what can we do to enable the body to be at its best. Even if you think about cancer treatment, the latest new cancer treatments are more about saying, how can we enable the immune system to do what it does to defeat the cancer cell, rather than throwing toxic drugs at it in an attempt to kill some cells. Doesn't work for most cancers. As you rightly alluded, diabetes, there is now the possibility of reversibility in some patients. And I think the same exists with pain. Some kinds of pain, you can retrain the nervous system and achieve a very, very different outcome. And I think that's what the newer techniques like pain reprocessing therapy are considering. They're saying, well, for the right patient, chosen well, supported well, therapeutic alliance, there is a very different outcome than just saying, live with it, but try to find happiness within it, which I think should be definitely aim for everyone to get access to those support and techniques, because that itself is a fundamental problem. But we should engage the mission of hope to a far bigger, wide audience.
Yeah. Agree. Yeah, thank you, Lee. I'd love to bring you in here because you'd have had a lot of contact with the healthcare system over the years. I'd love to hear a little bit about kind of what's been unhelpful, what's been helpful for you in that kind of context that you've had with the healthcare system.
Yeah, I mean, in context of the healthcare system, you've both just said it. I think it was Kipling that actually wrote that words are, of course, the most powerful medicine known to mankind. And the words we impart, the sentences we use, it's how they're received by us as the individual. And as a guy in his 20s, and I'm not alone in this, I hear this is the common one, it's just something you've got to learn to live with. Not factually incorrect. it's just not very kind. It doesn't feel very kind. It feels like a doorway to a dark room. And we spoke earlier about the quote about the absence of a benevolent other. That kind of says you're on your own, Jack. And if I'm presenting as I was with excruciating low back pain in my low 20s, and I'm being told it's just something you have to learn to live with, I kind of feels like a life sentence. This is you. Go away, deal with it. Whilst it's not meant to harm, it's the one that when I speak to patients, and certainly for me, that doesn't help. There are kind of ways to phrase that. There are kind of ways to talk to people around that, because persistent pain can be part of your life. It can be a guide, it can be a friend, it can be your superpower. It does not have to be your life, but it can be part of your life. Whether that's kinder or not, I don't know. But learning to see your pain as an early warning system that can provide you with informed choice, different ways to plot that path. So people don't think, well, that's it. That's my life sentence. It's here and I have it for life. So the learn to live with it, is a difficult one. It's the one I think people struggle with, the all in your head stuff. It's well, there's nothing wrong with your scans. You shouldn't be in this kind of pain. What I am, the lack of validation, being disbelieved, the lack of empathy. There's lots of things, and words can harm, but they can also heal if we use them correctly.
Yeah. Nice. I was thinking, when I was saying that to people, I was trying to be helpful. I was trying to be helpful. Like, actually, we keep, if you keep chasing this cure, you're going to be constantly disappointed. So let's accept the fact. You need to accept the fact that it's not going to get any better, and then we can move forward. But now I realize that is really unhelpful. Having heard you and having heard other people, it doesn't land well. And I suppose I got that from patients as well. Thinking, wait, I've got to live with this. Is what you're saying? And that was never what I was saying. And I think one of the reasons for saying it was that I felt too much pressure on myself to kind of solve it and to fix it and to sort it out. And so therefore it was almost like putting it back to the person. So no, actually you've got to sort this out. And it's not that there's no truth in that. People do need to kind of use their internal resources and things to do that. But it's really unkind if you're just laying it back at people's feet. And so we definitely don't want to be thinking that's what we're doing, I suppose, with coaching. I'd love to hear a little bit about, for you, Lee, then what is it that made the shift for you in terms of your relationship with pain? What changed for you?
I think, and I'm going to use that word, pain management program. It feels, when I hear so much about pain management programs, they are a little bit or a lot of it of a postcode lottery. The efficacy of some are really poor. Some of the stuff I hear back from them are all biomedical based. People say, I went to pain management, I got an injection, I got new drugs, that's not what my pain management program is about. So maybe I was one of the lucky ones. And, I went to the Royal Halmshire Hospital here in Sheffield, and it was the first pain management post-COVID. So we were all sort of like this. It was really quite informal and uncomfortable. But I'd refused a pain management program multiple times. That's not my kind of pain. Mine's that real stuff. That's not going to be no good for me. But I think, one of the shifts inadvertently was possibly a conversation maybe around December 2021 with my GP. And I was begging for help. I knew what was coming. I was going to have to go off work. And I did go off work. And it felt like that it was the end of that kind of part of my life. The only thing that came back to me is, well, we could try morphine. Now, I'd had morphine before, after I'd had a hip resurfaced, and it made me violently ill. It was a horrible, horrible experience. And my reaction was almost like well, that's not going to help, because then I'm going to feel worse than I thought I couldn't feel. And it was almost maybe it was that kicker to make me think, you know what, let's see what the pain management program holds. By the time I got onto it, I was signed off work. I was off long-term sick. I didn't think I was ever going back. I was in such a bad way. But, we talk about the patient activation measure, and I was that, activation 1 level patient. I was expecting to be fixed. I was chasing the GP to give me more meds. Could there be a surgery? Could there be more x-rays? Could there be more MRIs? But, I think it was the end of the line, and I still don't know to this day fully what it was that made me say, let's just do it. I think it was almost that feeling of last chance saloon. But I went in there overwhelmed. I went in there disengaged. I went in there thinking, I'm really not sure about this. I'm really, really not. And I I was reluctant to go back for the second week, but I did. And after 9 weeks, I would suggest I'd shifted from patient activation 1 to 2. Or I was there. I was in that liminal space of shifting, because what I found in the pain management program for the first time in 30 years was empathy. I wasn't judged. We were all heard. And there were little snippets of education. They were giving us real life experience of neuroplasticity. That word was never mentioned. It came about with my self-studies later on, but they started to do things. And one of the things, well, we're going to do a kung fu exercise with you. It's like, are you absolutely off your heads? You've got a room full of people, some rocking up in wheelchairs and limping in on morphine, and you want to do kung fu. But it was just their way of doing things. It brought a laugh. And what they were on about was Qigong, which is, that mindful form of movement. And we either sat, we stood, we did what we did, and we did Qigong. We aligned it with breath work. And I can remember coming out, and I can still, I'm tingling as I'm saying it. So that's how it resonated with me. We remember opening our eyes, and I looked around the room, and we all had that same look on our face. What the hell just happened? I'm not saying the pain went away. It didn't. It shifted. It changed. It's that somatic experience of what was going on that I, again, later learned to understand. That how on earth did that? What was that about? We got little bits of education, but the biggest thing was the peer support. It was finding my tribe. We were walking in there like Uncle Albert on his walking stick. We were walking out like Usain Bolt. There was something about what they were doing, the way they were talking to us that really worked. And by week 9, I didn't want it to stop. I just did not want that program to stop. But what it did, it shifted me, or at least moved me to that liminal space between patient activation 1 and patient activation 2. There was just enough for me to think there's something in this that I need to look at, because things have happened that I can't explain. The Qigong, I was doing it every day, and, I was back out walking and thinking, I feel better for this. This is kind of against everything I've ever thought. And it was about a year later, and I spoke on the podcast with Deepak recently about this one, and it was about the Rangan Chatterjee Howard Shubana podcast. And it was fundamental in my recovery. Had I not heard it, maybe I'd have stayed in that liminal space. I do not know. Because Howard Shubana spoke a line in that podcast, not only that changed my life, but provided me with the diagnosis I'd been waiting 30 odd years for. Now, nobody would have known that was the diagnosis because they didn't know my story. They'd never heard that story. I'd never been asked to share it, anything like that. But I knew it. And when Howard Shubana spoke about emotional trauma and physical trauma sharing the same neural pathways in the brain, it stopped me in my track. Remember exactly where I was on that day. And he alluded then, I'm probably paraphrasing now, that, emotional trauma can present as physical pain. I knew my story, the ACEs, the PTSD, the CPTSD, it was all there. And it was like for the first time in 30 odd years, somebody had just explained it. Well, if that's true, then that's why I hurt. That's why nobody can explain it, because it can't be seen. And from there, it was a real quick shift, into thinking, well, actually then if emotions drive pain, well then I recognized that, because the reason I ended up off work because I'd lost control of my emotions. It was almost like it was a mental breakdown. It was a physical breakdown. And I started to recognize that, well, I can do something about my emotions. And the more I played with that idea, the more I saw my body react. The quicker I came off the medication, the tapers were a little simpler. And I started to join the dots. And within 3 months of hearing that podcast, and this is a guy who was told once, never ride a bike, not with your spine, not with that MRI, don't go near a bike. In 3 months, I was riding around the north of England with Deepak, Ollie Hart, Lorimer Mosley, and the entire flipping pain peloton. A family I've now made and kept for life. People in there that they are my tribe. I then went to ride a Northumbrian tour of 85 miles. I rode London-Brighton. And in October 23, I went across Britain on a bike with 5 friends, all living with chronic pain. That was about 7 months from that liminal space between 1 and 2 to being a guy that probably was, hitting that activation now. That ultimate goal of maintaining, pushing on, giving back, and really working well. It was the very best version of me ever. So for me, my relationship, and I think that's a really good way of understanding pain, changed. PMP was the shift, but just that one word, that understanding of emotions and pain. And I was off on my bike.
Interesting. Yeah. Sorry, Deepak.
No, I just wanted to use this because when me and Lee, we do, the coaching within the Peak Health, and when we've shared the stage there, I never failed to be sort of impressed or impacted in some way the way Lee presents these things there. So thank you, Lee. It's always nice and goosebumpy to hear that critical shifting point, because I think, Tim, we have never really funded our system to support the patient in this extended manner. We think that we just will give a funding for 6 sessions of a PMP in secondary care, or that somebody would do 4 sessions. And we almost try to bring everyone into a single one size fits all. You will get a 6-week PMP or a 4-week PMP, and that's all it is. And then you'll have to wait 12 to 18 months. But I think this is what is all about, the new change in understanding complexity, in understanding how, for example, Lee's journey, even though it can be a long journey, the recovery is still, by extension of the NHS, is still long. It's not a 6-week PMP, but the PMP was a changing point, and then it took a further 8 or 9 months of a lot of things falling into place, including an ecosystem of believers, friends, tribe. And I think that is the challenge and opportunity that we have with this neighborhood health, with this long-term plan, is we step back and say, well, how can we change the ecosystem to ensure that we give as many people these opportunities to sow seeds, to give some time for the saplings to emerge, to create the right kind of fertile soil for that kind of change to happen en masse. We are putting a lot still on the person to do for themselves. And we are not, and I think in the same breath, we are not doing enough for our colleagues in secondary care and in primary care and intermediate care, because we're just expecting them to keep doing the conveyor belt and not realizing that people need a long-term wraparound support when they have gone through an initial program of change. They need a longer-term coaching. That is, I think, the crucial missing part. And I don't know where it will come from, but I do feel that the way, the direction, the noises that are being made in terms of the NHS long-term plan are encouraging. I just hope that it also is accompanied by appropriate funding and recognition of this unique journey that everyone has.
Yeah. And we're going to come on to kind of what the part we think coaching can play. But I suppose what I'm noticing from that story as well, Lee, that you shared, is that it wasn't just one thing. I know that was that one line that you heard, which really resonated with you. But I wonder whether it wouldn't have resonated with you if you hadn't had all the other stuff that had gone before it, I think, as Deepak was saying. And I know you talked about the kind of the activation, which again, some people may be less familiar with it and different levels of activation, but activation is people's confidence, knowledge and skills to manage their own health and healthcare. And people at level 1, which I think is where your starting point, will kind of think, actually, my health and well-being has nothing to do with me. And often for really good reasons, because there's a whole lot of other stuff which is going on in life, which means health is way down the list of priorities. And level 2 is like, I've got a role to play. And even at that point, which is what you were saying, even to think, well, actually, I've got a role to play. And then hearing that kind of podcast and Howard Schubiner, who speaks really well, doesn't he, about that connection between emotions and pain. And I think he talks about emotional awareness and expression therapy as one of the things that he feels really works for people with long-term pain as well. So, and PMP programs, so pain management programs, PMP programs as well, play their part, don't they? That was part of the journey. It wasn't the thing. It wasn't this silver bullet, but it was kind of part of the journey. So how do we weave all these things in? And I suppose meet people where they're at. And I may have preempted some of this, but I'd love to hear, both of your thoughts really in terms of what you think health coaching maybe offers to people with long-term pain or persistent pain. What would you say? I don't know who wants to lead off with that one.
Lee will lead.
Well, thank you, Deepak.
But the name lends itself to leading. Come on, lead.
What does health coaching lend to this? It lends the one thing we're missing, and that's time. That's time. It's safety, and it's that safe space and that time for many people with persistent pain. The pain isn't there to be seen, but it can be heard. And for me, that's where health coaching can really lend itself. And I'm seeing it now as a coach working within a pain service, the results that are coming out of this. The work's not us. We just turn the torch on for people in a dark room. We don't do the doing. Health coaching is about taking that doing with approach, not that doing to approach. we're not rats in a lab to be experimented on. We are experts within ourselves, and if we ask the right questions, and if we are curious enough with those questions, and we can enable people to think a little clearer for themselves, like Nancy Klein sort of talks about. Can we then just spark that curiosity? Because the empowerment for a recovery journey, it comes from within. It's that shift to that internal locus of control. It's about us becoming the driver of the bus, not the passenger of the bus. And as coaches, we provide the safety, the space to guide. Sometimes we may hold a hand a little bit. Very often, sort of in conversations, people come back to me and they're aghast by how much time they have to simply just talk. What's important to you today? What would you like to talk about today? They've never been asked that kind of question. They're being asked, you've got 5 minutes, pick one. Well, I could give you 30. Which one shall I go for? I'll go for the one that actually maybe sounds like I'm having a heart attack, and then maybe listen. The system that we have right now is not built to provide time. Health coaching, that's the missing piece to the jigsaw. Deepak.
No, very well said, Lee. I think it's that opportunity for continuity and maintenance of context, I feel, that coaching brings to the conversation. Because ultimately, I think we've all trained or been trained as physicians to provide episodic care. The incentivization in healthcare, insurance-based cover, everything is episodic. Do something, treat something, be paid for it, and there needs to be an exit point for a system to be then paid, and that's how it is. But when you think about long-term conditions, which is what we say is unsustainable and is going to break the NHS, and by 2040, I think the Health Foundation estimates that chronic pain, diabetes, and mental health, depression especially, is what's going to be the 3 biggest challenges that the health system and the general public are going to struggle with. And I don't think that episodic care for those conditions will cut it at all. We've heard Lee's journey now, and that kind of journey is not a linear recovery. There will be ups and downs, and much like life, it's going to be a squiggly line. And that means that there needs to be some support that we should be able to offer as a system or make available. And I think coaching is what is coming up to fill that gap in that perspective. I think in my book, I took a kind of a marketing analogy that up until the last generation, i.e. during our teens and during our sort of first year of life, the 1990s, we had a typically DFY, done for you. You have a problem, you go tell your GP will sort it for you. You were not really expected to take too much ownership other than to passively hand over your health to the care of the specialist or GP. And then within a short span of 10 to 20 years, we've just completely pushed it to DIY. Do it yourself. Just take a set of exercises, download a piece of paper from the internet and do these things yourself, and discharge on the second point from a physio or from any other service out there. That in both human cognitive abilities as well as in any system, and including other industries, we realize that the jump from done for you to do it yourself is too much of a gap to bridge. There needs to be what marketing calls DWI, done with you. And I think that DWI is the fact that, does it need to be one-to-one? Can it be groups? Which is scalable? Which is sustainable? Those are the critical questions we need to ask. And I think coaching, again, sits in that space of saying, let's do it with you to give you the confidence, the agency, the empowerment. And at some point of time, when you feel confident, you will go. And I think that's how I view coaching, as sort of the training wheels of someone learning to ride the bike, some kind of support and proper instructions, hand holding when you want to build something that you will treasure. IKEA tried to do that. They came in saying, oh, here's a set of instructions, go away and do it. Some of us could do it, but very soon they realized there's actually more value in providing someone to come and build it for you or support you in doing it. I think that is where we need to say, and this is where I feel coaching makes the difference, supporting people in that transition from DFY to DIY. and to be there with them every step, recognizing the life's quickly lines, demands increasing and decreasing levels of support over time.
Yeah. Health coaches are uniquely skilled, aren't they, to do that piece of work? I mean, we would say that probably all healthcare professionals should have some sort of health coaching training. We would say because it's also mindset, isn't it? It's like if I knew that this person in front of me has the most important contribution to make, how would I consult with them? You know, it wouldn't be to tell them what to do.
It's been a game changer in the way I now consult. In the last 5 years in my pain clinic, I can notice it. And I've had my junior trainees, anesthesia trainees, or GP trainees who sit in with me. Some of them have actually said, well, that is so different to what I heard another pain consultant, another medical consultant in their consultations. Because yes, my clinics would overrun by around 15, 20 minutes. Unfortunately, they do. But it just means that where a 20-minute follow-up or a 10-minute follow-up would have been, yep, did the injection work? If not, okay, I'll put you on the wait list for another one and see you in 4 months or 6 months. I just take that extra bit and say, well, if this didn't work, what are you doing now to look after yourself? If this didn't last for more than 3 months and my waiting time is 6 months, what would you do in those 3 months to look after yourself? And I just ask those open questions. I give a little bit of silence and I'm just wondering, are they going to say something that I can then use to say, so you are able to do some things for yourself. How can I help you do more of that? And I think that has been a radical shift because so many patients will actually say, I do feel hopeful. You know what? There are things I didn't realize I was doing. Okay, I would do that. And suddenly the waiting doesn't feel long, or the waiting feels like something they can prepare to make the injection worthwhile, possibly. And if it doesn't work, it still doesn't mean they have lost all hope or they feel hopeless. There's still other things to be pursued.
Thank you. And I just want to just check in with Lee. Is there anything you want to add to that, either in terms of your experience of being someone who's living with pain or as a pain coach? Is there anything you want to add to that?
I think it's been eye-opening for me working as a pain coach, because I don't even know if the guys at the pain management program in Sheffield realised they were working in a coaching way. But my reflection now, training with Peak and working as a coach, is that they were, whether they knew it or not. But maybe, you know what, just good healthcare is just good care. Maybe that's what I received. I think my philosophy is, can I give back what I received to others in my position? Because I know the ingredients are right to bake that cake. Not everybody's going to like the cake. Somebody wants coffee cake, someone wants carrot cake, someone want, vanilla, strawberries and all that kind of stuff. The cakes are different, but the ingredients are right within what health coaching does. And it's an absolute joy, and it excites me to be able to do simple things for people and see astonishing transformations that they have done themselves. We are changing people's lives. And it's not just persistent pain, it's diabetes, it's mental health. Health coaching transcends healthcare. It transcends everybody. We can all engage with a health coach. The impact I'm seeing personally from the persistent pain perspective is I was aghast by the difference we're making. I really, really am.
So good to hear. So good to hear. I am conscious of time, so I'm going to kind of move us on a little bit. I'd love your kind of reflections both, actually. So what one belief about pain you'd love the listeners to challenge? So what's one belief about pain you'd love listeners to challenge? Who wants to lead off with that one?
I guess maybe I'll take this one. I think from my medical hat on, I probably would say that pain is not an accurate indicator of a damage that is beyond repair. Don't be worried by words like degenerative or all of those. So words really matter. I think I'm going to paraphrase Lee again here, but it is just that is what I'd like listeners to be challenged by, that your pain is about a system being overprotective and telling you to go be a detective to look for what is it that it is feeling threatened about. That's the journey I want the listeners to take on.
Yeah. Lovely. Lee, what about you? What's one belief about pain you'd love listeners to challenge?
Well, I think I'm going to have to effectively coin the phrase that great minds think alike, because that is exactly what I would be asking people to explore. The message about hurt does not necessarily equal harm. We know you can have injury with no pain. You know, how many people, everybody's done it. We wake up in the morning, we look down the leg and think, where on earth did that great big bruise come from? Or where did that cut come from? Now I've took a salt and vinegar, Chris. I don't remember doing that. You know, the body has reacted by creating a bruise, or we've cut our skin, but we've not noticed it. We can experience injury without pain. When I suffered a grade 3 Achilles rupture, 6 weeks after I rode across Britain, there was no pain. There was absolutely no pain. And Deepak will make me tell the story anyway if I don't. But, you know, I was on the dance floor, you know, and I was jumping around to House of Pain. It's hilarious, isn't it?
Give the name of the song.
It's just fantastic, isn't it? And it just felt like I'd been kicked in the back of the leg. Couldn't stand up. Tried to stand up 3-4 times. There was no pain. Dragged myself off the dance floor on my hands and knees. Kids laughing at me, you know, sort of saying, I said that Jack Daniel was too much for you, you know. But 15, 20 minutes or so later, once I'd settled, why won't my foot move? What was that? And it went back to a conversation I'd heard of a footballer explaining a similar sort of injury about a pop he'd experienced. He felt it was like he'd been shot. And it just came back to me, that conversation. I thought, yeah, that was it. Then I experienced pain. Then the pain came through. Once we'd made the connection with damage, then the pain came through. You know, we only have to look at Lorimer Mosley's snake bite story. It sits there too. He had no idea he thought he'd been scratched by a twig. You know, but we can also have pain with no injury. And this is persistent pain. Pain that's just random. It comes on with no necessarily no cause or effect. It moves around. There's no diagnoses to be found. There's no explanation. You know, phantom limb pain is the perfect example of this particular pain without injury. And this is the mechanism, correct me if I'm wrong, Deepak, is the same sort of behind persistent pain too. We can hurt when there's absolutely no explanation. And learning to understand that why we experience pain is very often not down to any sort of tissue damage, and it's more down to what might be going on socially for us, what's going on psychologically, where are our emotions at the moment? Can we learn to interpret the message a little better?
Yeah, and I wish I'd known all of this like the years ago when I was working as a GP, because I think I did kind of hear the pain story, but I think I might have done more now to explore what was going on in life, what was going on around the time that pain started. I think I'd have done much more of that. And that's probably one of the things I'd ask people to, when they're hearing the pain story, firstly, take time to hear the pain story, but also ask what was going on, what else was going on around the time that pain came on, would be a really good thing I'd encourage people to try out. And I wonder whether there's anything else that you might, again, ask either a healthcare colleague, whether that's a coach or another healthcare colleague, or someone who's living with pain. What's maybe one small experiment, one thing you'd like them to try this next week?
Thanks, Steve. You know, and I'm going to go with this one because it's going to form part of the new training we're doing with Peak. It's a resource I created at Pure, and it was a learning experience I had myself. And it's something I'm working with. And I've worked with a lot of patients on this one, is looking for the whispers. We call it looking for the whispers, you know, and on reflection, and I once asked the person to tell me or to communicate with me, you know, when did you realize, you know, that it was all too much? Or when did you realize that the pain was becoming overwhelming, or it was, you know, you're doing too much? And that person literally sort of said to me, I just buckled and collapsed. Okay. Well, you know, I'm not a medical professional. I've done my lifeguard training, but sudden collapse is not necessarily the early warning signs in pain. And it was about what you're experiencing at the time. It was overwhelming pain. Thinking back, was there anything that maybe came before that? Was there anything you noticed before that? And we went through this for about half an hour, and we realized it was, I've been feeling a bit fatigued for a few days. Okay. Was there anything else? Were you feeling anything else prior to that? And the reflection was, I'd felt a little unwell, a little bit like coldy, kind of flu-y sort of thing. Okay. And had you noticed anything else? Well, my sleep had not been great. That had been disturbed. Okay. And anything else that had been going on for you? My diet had been appalling. I'd been eating the sugary snacks, the high carbs and things like that. And okay. And anything else you noticed been going on? I've been so irritable. I've been really, really irritable. You know, when you're sitting down next to somebody and they eat crisps so loudly, you know, things like that have been winding me up. And any other things? Yeah, I'd become really clumsy. I was walking around the kitchen, I was dropping things, I was banging my toe on the table. I did this 3 days ago, by the way. So this is me listening for my whispers. I'd become really, really clumsy. My thinking had become a little bit foggy. I wasn't quite myself, and maybe I'd been having unwelcome thoughts and feelings. So what was
You
the
do
first warning
realize
sign that pain was on its way? It wasn't the sudden collapse. It wasn't the overwhelming pain. The whisper was maybe the foggy feelings. It was maybe the unwelcome thoughts. It was maybe the clumsiness. What would happen the next time you noticed yourself getting a little clumsy and you chose that point to take the break? What might happen differently? And without going into full disclosures, it was a bit of a rip-roaring success. So for me, can you experiment with what are your whispers? What are the early warning signs for you that we might be starting to change lanes, change that pathway? Because the overwhelm, the pain, the fatigue, the crash, that's the end product. Our body has subtle ways, our mind has subtle ways of trying to get the message across a little more gently first.
Nice one. Nice one. I mean, it was resonating for me a little bit. I know Pete Moore in the Pain Toolkit, it talks about kind of in terms of pacing. So you need to stop before you need to. Do you know what I mean? You have to stop. It's not waiting for the crash. Or not waiting for the thing to kind of really kind of be powerful. It's kind of like, so paying attention to those whispers, Lee. I really like that. Deepak, I know I'm conscious of time, but Deepak, I'd love to hear what you think. So what's one thing you would encourage listeners to do if they're a healthcare professional, or if there's someone who's living with pain, something to experiment with over the next week?
I think if it was a healthcare professional, I would just be, barring the whisper, I'd be saying, can you just make that extra time to listen? We all, as healthcare professionals, are told that we don't allow the patient to finish their story. And I just would like to say that they experiment. Can they try? Can they just put a timer on and say, welcome to the patient, sit down, and can they give the patient 3 or 5 minutes of time, especially if they're in secondary or intermediate care, there's a bit more time. I think in primary care, I appreciate it's a little tighter, but still, if we can give 3 minutes, so just listening and a little longer time is the experiment I'd be asking a healthcare professional. For a patient, because 99% of patients who come to my pain clinic are often coming with a flare-up of their pre-existing pain, I almost have it down almost like a medical 60-second hack. I just ask them, do you feel that you've had any fall or injury to account for this pain? Do you feel that there's any swelling in that area of pain or fever? And if the answer to those 2 questions are no, then my experiment to you, to the listener, is can you just respond with a little bit more slowness and kindness rather than urgency? Can you just ask the same question that Lee said, but can you just ask and think about rest without guilt and curiosity about what else has changed to make your nervous and immune system feel threatened, and to just take that one step back before rushing into a medication? That's the experiment I'd like them to ask.
Right. Oh my goodness, there's so much there, guys. I know we've spent quite a long time, and it's been absolute joy for me to kind of spend this time, because I know you do the kind of the pain courses together, and so we haven't had much chance to kind of catch up recently, but it's been so good. So thank you, Deepak. Thank you, Lee. Hopefully there's a lot of information. I've kind of made some notes for myself. I kind of moving from DFY to DIY, and how the health coaching I might need to kind of fill in the gaps. And again, from Lee's journey, I suppose it's hopeful, but it's not one thing that's going to work. And our job, I think, is to kind of meet people where they're at and to develop that curiosity, but in the context of compassion and empathy, which are kind of what I've heard from both of you. And pain isn't just something to fix. Pain is there for a reason. It's kind of like being curious about what is that pain trying to tell me to some degree. And I suppose when we understand it is then what becomes possible from that. So thank you, folks.
We talk for 1 hour and Tim just compresses it to a 1 minute snippet. Honestly, Lee. No, nothing else. That's it. Yeah, that's it. It's just going to be one shot, isn't it? That's it.
Exactly. 30 seconds, probably of me actually, but thanks very much. But really, really good. And I suppose what I know from this episode is there'll be lots of different bits which are going to speak to different people. And I think that's the joy of having both of you on, is you're going to speak to different audiences as well. And people will hear what they need to hear, hopefully, about pain. And if they want to find out more, you've already referenced some people as well as you've gone along. So there'll be more some more people that they can dig into after. So thank you so much for your time.
Absolutely lovely. Thank you for having us, Tim.
Thank you very much.